Friends, Pradeep Pendyala. Today I'm going to talk to you something very interesting which keeps coming in the exams very frequently. That is TEG. TEG is nothing but thromboelastography. It was first described way back in 1948 by Hertert. He was the one who described thromboelastography for the first time. It is nothing but viscoelastic clot assessment. Okay, it is assessment of viscoelastic clot. If the rotational, there is slight difference between ROTEM and thromboelastography, where in ROTEM, rotational thromboelastometry is normally evolved from TEG. Okay, both devices generate output by few changes which take care of viscoelastic strength of a small sample of blood, and which is nothing but 300 microliter of clotting blood is assessed, and viscoelastic strength of the small sample of blood is visualized, and through constant rotational force. Okay, still confused? I'll tell you more. This is nothing but point of care, POC, one of those devices. These are point of care devices which allows visual assessment of blood coagulation from clot formation through propagation, stabilization, and clot dissolution, and computer analysis of this output of this clot formation and dissolution is taken care of. And whenever we see these things, normally they give a lot of information, especially to treat high-risk populations, especially those undergoing cardiac surgery or suffering from blunt trauma. So this is that it has a huge advantage. This point of care elastography, thromboelastography, has huge advantages. One, it has rapid real-time bedside test with simple methodology. It can diagnose coagulopathic bleeding, it can guide transfusion therapy, and decrease the use of blood products. That's a huge advantage, isn't it? And it can predict the clinical efficacy of therapeutic agent affecting blood coagulopathy. But interestingly, it has got few limitations which you must be aware of. See, TEG has a sensitivity and specificity that may vary significantly in different populations. Patients taking anticoagulants and antiplatelet agents are major concern in trauma patients, isn't it? And warfarin is invariably taken by these patients. And what happens? And half of this patients on warfarin, our time may be normal in both TEG as well as other tests. But what happens? TEG may miss clinically significant coagulopathic state if the patient is taking warfarin. Hence, in such patients, INR is still the gold standard for monitoring warfarin therapy. So this you can mention while talking about thromboelastography. And the need for point of care testing has resulted a lot of change. Like, there used to be limitations in central laboratory, the results coming to you when you're treating complicated cases, especially in ICU settings. And POCT can be performed on site in the operating room or an ICU. Decrease in the need for blood and blood component which I just mentioned. Blood components are packed red blood cells, platelet, fresh frozen plasma, cryoprecipitate. And it has been shown that POCT in transfusion practice, when you are using thromboelastography, it has remarkably reduced the requirement of blood transfusion by correctly telling the coagulation state and analysis of platelet function as well as abnormal fibrinolysis. These are all identified. Normally we used to depend on coagulation tests like PT, APTT, platelet count, INR and fibrinogen levels, which takes a lot of time. But point of care testing gives you immediate results. Maximum thromboelastography takes around 26 minutes to 30 minutes, and rotten it takes just 15 minutes, 13 to 15 minutes you get the results. So there's a huge advantage, and it measures physical properties of a clot using stationary cylindrical cup that holds the blood sample and oscillates at an angle. A pin suspended in the blood by torsion bar. Motion of this torsion bar is monitored in different phases of vitroplatelet and clot interaction, as well as fibrin formation and lysis. This analysis provides a graphic and numerical display. So what you see in this display, that's very important. And I'll tell you something very, very interesting about this. And you see in thromboelastography TEG tracing, you see R, that is reaction time. K is nothing but kinetics. Alpha angle, that's the slope between R and K. The angle is, you have to know that angle. And MA is maximum amplitude, and CL is clot lysis. So you have to know all these things, and you come to know about this, and you get a good information about the thromboelastograph and its usage. Thanks for patient listening. Have a wonderful day. Happy Ashtami. Today is Ashtami, and have a wonderful day. Bye-bye. Take care.